I would like to introduce our next speaker, Michael Harper, cardiac intensivist from MedStar Washington Hospital Center. Please.
Well, thank you, everybody. That was a tough act to follow with 30-year longitudinal outcome data for that patient population. I'm going to talk to you about something that has little to no data whatsoever, and we're going to talk about the ethics of ECMO when there's no way out. And this is a topic that I have somehow gotten aligned with over probably the last 5 years. I don't know if it's from being in the wrong place at the right time or the right place at the wrong time. But here we go. It's a touchy subject. So I have no relevant financial disclosures, but I will disclose that some of this topically is emotionally charged. I've been accused or likened to this individual with some of the things that we'll talk about here. I don't think that's a fair characterization though. So best place to start is in the beginning. So when we're talking here, we're talking about, if I can contextualize this a little bit. Nobody starts the process of putting a patient on ECMO with this foregone conclusion that we are not going to have a pathway out, whether that's recovery, advanced therapy, or some other adjunct that's going to get us off of the support that we're on. So the most important thing I think we can do from the get-go when we have this conversation is talk about setting expectations. Right? Everything begins with the consent process, right? We offer ECMO as bridge to recovery or bridge to some destination, transplant, LVAD, whatever. We have an understood mortality rate for pretty much everything that we offer ECMO for at this time. Some of that is more understood than in other scenarios, but all of that has to be clearly communicated at the time of consent. And that sounds like a foregone conclusion, right? Who doesn't do a good job of consenting patients? Lots of people, all the time, every day. So even if you do a great job at the time of consent, that's not the end of it, right? Consent is not a piece of paper. Consent is a conversation. Consent is a process. And our goal should be to achieve an appropriate level of understanding with the patients, with their family members, sometimes with our staff. And we have to clearly delineate with patients and families, what is the criteria to stop up front? And we should talk about that not just once, but multiple times, and keep that expectation clear in their mind. We're meeting people as a routine part of our job on the worst day of their life in a lot of instances. And the emotional state of being that they find themselves in is not a rational one. And so we have to repeatedly give them this information so that it can be, so that it can stick. Most of the failures that I'm going to talk about here are not failures of appropriate care. They're not failures resulting from medical error. It's a failure of communication. It's a failure of meeting expectations. And it has a horrible, horrible outcome. The flip side of this is with our own teams. We have to manage our team expectations, right? The frontline caregivers that spend the most time at the bedside can have a vastly different experience in long-term patient care than the rounding physicians, the APPs, the surgeon who primarily took the patient to the OR. We saw a really nice pie chart of time in the OR versus time in the hospital. I think that characterizes how we can internally, on the interdisciplinary team, have our own malaligned understanding of what's going on and what is appropriate. So as much as we have conversations with patients and their families, we have to have conversations with our team. We have to have our team involved in those conversations. And so they have to be included in that and feel a part and have their own agency in the process. So have two cases I want to discuss, and I strongly encourage audience participation. I'm going to ask questions. The only participation required is showing of hands. I feel like that's a low bar. Hopefully we can meet that. I don't know how the YouTube community will respond to that, but hopefully we can get some feedback there. So first case. So this is a 40-year-old male, chronic non-ischemic cardiomyopathy, had severe aortic valve insufficiency, which was secondary to a failure of a prior bioprosthesis, which had been, was a tissue AVR done in a South American country that I cannot recall off the top of my head. His pre-op LVEF when he came to us was less than 20%. He also had severe pulmonic valve insufficiency, which was more than just functional. He was not a candidate for any advanced therapies for multiple reasons. And every time we talk about things like this, everyone's like, well, why not? Why not? Let's just take that as gospel that's the fact, and there's no pathway out with advanced therapies. So given the fact that he had no other options, that he was an otherwise healthy gentleman with severe valvular disease, the decision was made to offer him a high-risk reduced sternotomy with redo AVR and a PVR, all with Impella 5.5 support. So first question, does this seem reasonable? Can I see the yeses? Okay. No's? A lot of abstaining, okay. The yeses have it by a little bit. I don't think no is a wrong answer either. But this is a talk about things going awry, so obviously he got the surgery. So surgery itself was uncomplicated. So both valves successfully replaced, minimal intraoperative and postoperative bleeding. The Impella was weaning. He was doing phenomenally postoperatively. Once we got down to about P4 on the Impella from P7, he developed VT, which was refractory, VT storm, had hemodynamic collapse, RV failure, Impella sucked down, underwent CPR, and then was cannulated emergently for peripheral VA ECMO. We could have an entirely separate conversation about the appropriateness of that escalation, but regardless, that was the escalation that was decided to be performed in the moment. Despite triple drug therapy with antiarrhythmics, an EP mapping study, which was negative, we were never able to successfully wean him from ECMO because any significant reduction in flow support back into VT. Fortunately or unfortunately, at this point in time, patient's awake, he's interactive, conversing with his family. He's got 2 young children that are coming to visit him in the hospital. He's able to get up, do physical therapy. He's ambulating in the ICU. So what's next? Do we stop? Do we give more time? Do we have a stop? Show of hands, stop, stop, okay, stop. More time? Okay. I'm sure we can guess which one. Personally, I agree with you, but that wouldn't have made it into the talk. So he never demonstrated any meaningful recovery, continued to not be a candidate for any advanced therapies for myriad issues, PRA, social support, on and on. With a lack of exit strategy, we approached the patient and family to proceed to transition to comfort-directed care with cessation of both the Impella and ECMO. Neither of them would consent to compassionate withdrawal of support, and they would not entertain any discussions whatsoever about a timeline to target a transition to end-of-life care. There was no discussion whatsoever. So, show of hands. Continue current care. Okay. Stop therapy against patient wishes. We'll come back. All right, case number 2. 39-year-old female, past medical history of hypertension, lupus nephritis, on dialysis, Monday, Wednesday, Friday dialysis, as non-ischemic cardiomyopathy with an LVEF less than 20. She's on chronic immune suppression for her lupus. She presented to our hospital for evaluation for a heart kidney transplant. She was in SCI-D shock, which was honestly missed by the referring and accepting physicians. That was discovered on arrival, and she was immediately taken for an Impella 5.5 insertion to stabilize her so that she could be formally evaluated. So this was bridge to decision. The vessels were small, calcified, extensive bleeding complications at the time of insertion. She had complete circulatory collapse. She was emergently placed on peripheral VA ECMO in the OR. The Impella placement was completed immediately thereafter. She was hemostatic by the end of the procedure. She had about a 10 to 15 minute downtime in the OR with low no flow state before she be placed on ECMO. The immediate postoperative period, GCS is 3. She is having myoclonus. So what do? Stop. Give more time. Stop. More time. I honestly think more time is reasonable here. Myoclonus in the immediate peri-arrest period is not necessarily the signaling the end of times. Not great, but so we get more time for neuroprognostication. Further outline expected clinical trajectory with the family. GCS improved to the 7, and that was the peak. Neuroimaging, she's got ischemic cerebral changes and watershed distribution. Family meetings are cordial. They will not entertain discussions about discontinuation of any of the acute MCS platforms. Patient is officially determined to not be a candidate for heart kidney transplant. What's next? Continue care? Stop ECMO Impella support against family wishes. All right. We'll come back. So, show of hands, this is unplanned. Because more people said stop against family wishes than I was really expecting. Who has been a part of doing that in the past? Was that a traumatic experience for everybody involved? Okay. Show of hands, who had to go to court or someone went to court around that? Okay. All right. So, this comes up, I think, more frequently than programs like to talk about. I've had it happen a shocking number of times in the last 5 years. And I find that the universal problem is what I alluded to in the beginning, which is a failure to communicate adequately expectations and outcomes at the outset of these things. Both of these patients were emergently escalated to a higher level of support, and there was not a clear conversation to outline what the expected outcome would be and what would be it was not clearly communicated that we would stop if X, Y, and Z occurred. And so all of this got taken into the context of a patient population that is traditionally kind of mistrustful of medical providers, and it felt like they felt like we were shifting the goalposts on them. That's one issue, but is there guidance on this? Not a lot. So ELSO in the general guidelines, last updated August 2017. This is out of a 30-plus page document. We've got about 3 sentences. It says that ECLS should be discontinued promptly if there's no hope for healthy survival. Possibility of stopping for futility should be explained to the family before ECLS has begun. So I think we missed the boat on both of those. And in each case, a reasonable deadline for organ recovery or replacement should be set early in the course. This is all well and good, but practically speaking, what do we do in these scenarios? There's not much published about this. We have this one study there's one paper last published, I believe, in 2020. 2023 in the American Journal of Bioethics. Their overarching conclusion was that they found that existing justifications for unilateral withdrawal of ECMO support in incapacitated patients, and I think that's the important piece of this, led them to conclude that no existing ethical arguments existed for that would support that approach, but that if that claim is in fact true, then we should consider that ECMO as a destination therapy should be questioned. That's pretty strong language. It feels to do this, it feels like a very clear, rational, humane decision. But this can often be in direct conflict to like central core tenets that patients and families hold, whether those are cultural, religious, or just emotional. I don't want to die, I'm not ready to die, and I'm not going to just say, yes, I'll die right now. And then realistically, there are concerns on part of the treatment team for legal implications that can oftentimes lead to people capitulating to what feels like unreasonable medical requests by family members, by lay people. So we've got a problem that is low frequency and high complexity, and it's a catastrophic failure to achieve aligned expectations. And the outcome of that is moral distress for every single person involved, moral injury for every single person involved. Oftentimes, who has a policy in their as part of their program for this specific instance? This is what it took to get that for us. No policy or process existed to support us in this. The hospital's definition for futility of care these patients did not pass muster for that because they were awake and they were interactive. They were not imminently dying. We were talking about taking away a therapy that we had put in place. It made the legal team very anxious. Anxious lawyers are not fun to talk to. So when we look at solutions here, we have to address both patient family needs, but we also have to address staff and hospital leadership needs. So back to the clinical cases. So case number one, and I picked these two cases. I have a handful of others, but I like these two because it really bifurcates us into the two trees that I like to talk about. First patient, this patient had capacity to make decisions. And he prioritized two things very specifically: time with his family, and then the other part was based on his religious beliefs. He did not feel that it was in keeping with that for him to give up and say, turn off the machines that are keeping me alive. And so until such time as he became incapacitated or devices failed, he wanted to continue with all care. He got up, he did PT every day. He participated in care. He focused on getting adequate nutrition. He had time with his family. We had child life services available so that his children could be taken care of, his family could be taken care of, and they had good time together. Ultimately, devices failed, and he died after a total of 55 days on support. Second case. This patient did not have capacity to make medical decisions. Parents were her surrogate decision makers, and they would not consent to anything. After 4 weeks on support, patient was successfully passed an ECMO weaning assessment. The family would not consent to decannulation. Ultimately, what allowed us to get her off of ECMO was that she had catastrophic bleeding from the arterial site, and we were able to leverage that into consent to go to the OR so that she would not exsanguinate and die. We had similar complications with the Impella subsequently, with similar strategy involved. So she had a total of 63 days on acute MCS platforms and 97 days in the hospital before she ultimately died. So these cases for us precipitated a change in practice and approach to these difficult scenarios. This is an emotional toll that was taken on every person involved. So we took a three-pronged approach in an effort to prevent these experiences from being so bad in the future. So first is with the patient, then with staff, and then with hospital policy, because everything has to finish up with the lawyers. So in terms of patient, the approach here, this is the achievement of consensus with the patient, with the family, with staff, with the treating team. The consent process could not be more essential to this. We built in language into our consent form now that this is a trial of support. The language in the consent document now has that it is a time-limited trial, and that after 14 days, it is a every 7-day renewal of continued therapy. That if the team decides that ongoing therapy is not appropriate, we will discontinue. We have a focused approach to family updates so that we limit who is giving family updates, so that we are giving a singular message. So we're not giving mixed messages. Dr. A comes by and says this, nurse B says this, night shift doctor says that, and all three of them were different things. Family gets confused, then they don't trust anybody. And then we set very clear boundaries for what will and will not be done, and we hold to them. When your oxygenator fails, we are not going to replace it, period. Staff. This was probably one of the bigger impacts that we had. Everyone is experiencing staffing shortages right now. Emotions run high just to come in and do routine work. When you have patients like this who have been in the unit for weeks on end, it takes a toll on everybody involved. The interdisciplinary rounding is a big part of this, with a focus on keeping the team unified. Things are going to go wrong, but we built in a process and an environment so that we can discuss these things amongst the staff, called these peace rounds, patient ethics and communication excellence. And so we set that up with the ethics, with nursing leaders, ECMO leaders, advanced heart failure, cardiac surgery. Everyone who touches ECMO patients is a part of this. And then if we have a patient that is of concern, anybody can refer a patient for this. And then we will set up a time and have leaders come in and answer questions. Everyone can talk through things to make sure that everyone has a clear and shared understanding about what is going on, so that we can address, the goal here is to address moral distress before it ever kind of bubbles up into the surface and people truly become injured, scarred, and ultimately jaded or want to leave. Then finally, policy, which I think was on the back end one of the more important things to do. We have added specific language for ECMO futility that differentiates that just from standard medical futility into the hospital policy. So it is now, for patients receiving ECMO, futility is defined as the inability to be liberated from ECMO by recovery, transition to another advanced medical platform modality, or organ transplant, either at our hospital or a comparable institution. And so once we have ticked all of those boxes, hospital leadership, legal will support us, because we have a definitive policy that states that. In your own hospitals, you're the subject matter experts. You all have to dictate to hospital leadership what this language is. You can't let them come in and apply what is medical futility in the NICU to this patient population, because it's just not apples to apples comparison. So, bottom line, we've bifurcated these scenarios by patients that both have and don't have decision-making capacity. So in our own policy in terms of ethics and withdrawal of care, if a patient has capacity and they do not consent to withdrawing ECMO support, we will not do that against their wishes. If they deem that their life has quality and value, We will not make a value judgment for them and say that, no, it doesn't have value, so we're not going to continue that. We will put boundaries in place, as I talked about before. We're not going to replace the oxygenator. We're not going to replace your Impella, et cetera. We're not going to recannulate you because your artery is falling apart, things like that. Incapacitated patients, we talked about our consent process. We've added this language in. We will make the patient's DNR by 2 physician decree, and we will have daily meetings with the family to try and get us there. But if they will not ultimately consent, then we will set a date some days in the future. This is the day that we're going to stop everything. And that's just, and then we hold to that. I would give, this is personal advice. If you're going to do this, make sure that you're not layering this over a weekend or a holiday, because your legal team will tell you that if you do that, you are obstructing their ability to go get a court order, because they can absolutely get a restraining order to stop you from doing that if a judge feels so inclined. This has happened at a former institution where I was. So little rules of the road. But with that, thanks for your attention. Any questions in the brief minute or two I have left?
Thank you, Mike, for nice talk. Really, Michael, it's really difficult to make decision to withdraw a patient from ECMO, especially when it's young patient or an awaiting patient. It's really difficult. Thank you so much for talk. So any questions from audience?
Hi, Greg from Boston. Thank you very much for that talk. I have a comment about something that's very small in there, but you mentioned the trauma to families, the trauma to clinicians, whether they're ECMO techs or physicians, nurses, and whatnot. And something that I came across probably 4 or 5 years ago that really kind of blew me away in that trauma space for what we deal with death is a change in the term from DNR to something else. So DNR, do not resuscitate, can have certain meaning, as opposed to what some people have recommended, which is AND, which is allow for natural death. And I was curious if you could just comment on that.
So it's a good question. I don't get overly semantic, I guess. I know I typically don't use the language that we use in determining code status with patients or families. I talk about the specifics, like if your heart stops, if you go into an abnormal rhythm, if you stop breathing, I tell them specifically the things that we're not going to do. And I try and avoid anything that sounds remotely too much in our jargon, rather than to just speak very plainly about these are the things that we won't do. Is I think when people hear DNR, they hear do nothing. And I think the same thing would occur over time if we change that vernacular to we're going to make you AND or whatever else. I think they just hear that term and associate with this is nothing else is going to happen now. You're just going to let my loved one die. I try to focus on we're transitioning our care from prolonging life to promoting comfort. And then to do that, we're going to do this, this, and this, and we're not going to do this, this, and this. And because we don't have to tell them we're going to make you DNR to make them DNR. We have to have the conversation about the things that we will or won't do. That's all on the back end. So that's my approach to it.
One of the really challenging domains that we're exposed to is with ECPR, obviously. We'd like to make some comments around this whole set of sort of conversations in the ECPR environment. I know you haven't got a half an hour, But, seriously, it's a very difficult time. I think the concept of being well informed and, just telling them it very much is a quick resus to see whether we can do something. But I'm just wondering your comments.
That's probably I would equate a lot of these patients who had acute collapse and then no opportunity for consent to the ECPR population. I mean, functionally they're not, I think that Venn diagram was not completely overlapped, but I don't think there's a good answer. I think that's part of the Pandora's box with ECPR is, there's all this great enthusiasm to offer it, but there's a lot of baggage that comes along with that, and I don't think we have good answers for that yet. Certainly not. I think the environment in Europe and I guess non-U.S. countries in general is maybe a little bit different for this, but the attitudes around discontinuing life support, certainly in the U.S. patient population, at least in the Mid-Atlantic and Southeast where I've trained and worked, is I think very different than is approached in other parts of the world. And it's just fraught with this ethical quicksand. I wish I had a good answer for it. I'd probably not have to work night shifts anymore if I had good answers like that.
Any questions? Okay. So thank you so
Thank
much.
you very much. Thanks.
Yes.